Hello. It's not quite 3 o'clock yet, so we're still gonna wait a minute or so for folks to come into the room. Yeah, it just hit 3 o'clock. And of course, the second I start my webinar or the webinar, this kitten wants to pop right in. Always tries to make an appearance on Zoom. Hey everyone, we'll get going in just a minute or two. It's 3 o'clock and we just opened the room, so we're gonna wait a minute or two for folks to come in. This is showing the right screen. I forget to have my Spotify ready and like play a little bit of like pump up music before these webinars. This minute or two delay we have before we sort of hit critical mass in the room. Just wait like 30 more seconds. I think some folks might be having some tech issues because I'm seeing attendees pop in and out. So hopefully others aren't having internet problems. Okay. Oh, see that. Well, I will then get us going, just so we don't have to wait too long, and then I'm sure folks will continue coming into the room. It's getting late in the day, so meetings tend to kind of back up on one another. So thank you all for joining us today. My name is Frank Hood. I'm the director of Hep B United, and at the hepatitis. See, the second I started talking, she went and made her jump. That's Millie. My 11-year-old fluffy cat. I'm Frank Hood, the director of Hep B United, and at the Hepatitis B Foundation, I am our associate director of policy and partnerships. Part of what we do at Hep B United is host webinars on topics of importance to our partners. And I'm especially excited to have this presentation today. We heard a shorter version of this presentation at a recent coalition call, and it left our partners with quite a few great ideas and really just motivated to think and think about hepatitis B and approach hepatitis B work in their communities in a bit of a different way. So very excited to have a bit more of an in-depth dive on this topic. Coming from Fatima and her team. This is a excuse me. This is a webinar format, so attendees will start on mute. We ask that you introduce yourself in the chat, our attendees, just to let folks know who else is in the room. Oftentimes we see that folks know each other. Additionally, we will have time for Q&A towards the end today, and we ask that as you think of questions, please type it in. We have multiple speakers today, so it's possible that one of the ones who isn't speaking can answer your question right in the chat and really just allows for us to get through more material more quickly. Additionally, we are recording this session, and we will try to share out the slides as well. But if we end up leaving today with an unanswered question, we do try our hardest to go and get those answered before sending out the information to anyone who registered. So yes, anyone who registered for today's webinar will get an email with a link to this recording, and we'll also have this recording and slides posted on our hepbunited.org website. Sorry, I lost my mouse. There it is. For those of you who may not know about Hep B United, we are a coalition of coalitions, as we like to say. So we have 60 plus local and national organizations across 36 cities and 26 states plus DC. We've been around a dozen years now, and we're really focused on bringing together all of the local coalitions that are doing the work in their communities on this topic. And these aren't necessarily just individuals or organizations working on hepatitis B. Oftentimes, they're actually working on kind of more community health writ large and recognize within their community that hepatitis B is an issue. And so they go and expand their hepatitis B services off of some of their existing health services, whether it might be HIV, diabetes, high blood pressure. And today's presentation actually shows how taking sort of a syndemic approach and tackling multiple health issues at the same time can yield positive results kind of across the board. If your organization is not a part of Hep B United, but is interested in joining, I highly recommend you check out our website, hepbunited.org, as well as reach out to Shreya or myself to get a membership form. Membership is free. We're primarily funded by the CDC, so we are an integral part of the public health system here in the US. Today, I am super excited to bring in some speakers from the West Bronx. One of our National Advisory Council members, Fatima, has been leading just a fantastic program there. And as I said, talked about this program a bit at a recent coalition call. But we're going to hear from her and Daniel and Julie, who are two medical students of hers, about this program. And I think and so with that, I'm going to get out of the way and quit talking, and I'm going to turn it over to Fatima. I'm going to quit sharing my screen, and then Shreya, I think you're going to share slides, correct? Okay, we're seeing it. Thank you so much. I said West Bronx, I meant Bronx, my bad. Fatima,
Yes.
we are supremely excited. I will turn it over to you. Feel free to take it away.
Hello, everyone. My name is Fatima Omarufilo, Montefiore Starfish Program in the Bronx. I'm here with two medical students, and I know Dr. Emmanuel, who is the leader of the program, may also be listening, and if there's anything, he will contribute as well. So for that being said, I will pass it on to Daniel to start the presentation for screening for hepatitis B in the Bronx West African community with a blood pressure cuff. Thank you.
Hi, everybody. Shreya, you could go to the first slide. Thank you. So my name is Daniel, as Fatima said. I'm one of the medical students working with her in the Bronx community. Thank you very much for inviting us here to speak today on this very important and impactful topic. So to start off, it's important to understand one of the drivers of the development of this program, the Starfish program, as it's called, which is the growth of the West African population in the Bronx. The population has grown dramatically in recent years. Between 2007 and 2014, the population increased by more than 60%. And then between 2015 and 2019, 46,300 people of West African origin immigrated. And along with immigration comes major public health concerns. And two of the major public health concerns that have come as a result of this immigration is what we're going to be talking about today. And that's hepatitis B and hypertension. Next slide, please. So what do we know about hepatitis B in West Africa? Well, it's endemic in all of the West African countries, with an estimated prevalence in 2022 ranging from 2.3% to 12.3%. And it's the main cause of cirrhosis and hepatocellular carcinoma, and the greatest cause of cancer-related death in West African men. But unfortunately, even though there's such a high prevalence, there's some barriers to care that prevent people from getting treated for this disease, which include lack of knowledge about hepatitis, poverty, and inadequate health infrastructures. But it's not just treatment that people aren't getting. They're not getting screened either, and people don't know that they have the disease. And it was shown that less than 1% of people with chronic hepatitis B cases have been diagnosed. But besides for the barriers to care, causing this, another social problem is arising as well, which is that it's a stigmatized disease, often attributed as a sexually transmitted infection. Next slide. In fact, interview-based studies from Senegal showed that signs and symptoms of liver disease were attributed to occult forces. People were believing that chronic hepatitis B inevitably caused death and affected those who have been cursed or punished for wrongdoings. So not only was it attributed to sexual promiscuity, but people thought that they were getting cursed or punished for these diseases rather than because of medical reasons. And as a result, people who have the disease are ostracized and not spoken to because of this. And this leads to people not wanting to talk about the disease, not tell their family or friends that they have it, and it leads to them not getting screened or treated for it. Next slide. What do we know about hypertension in West Africa? Well, it was once an uncommon problem, relatively, in West Africa, but it's risen recently to become a major public health concern due to increasing urbanization and resultant epidemiological shift. And now, its prevalence ranges from 28.9% to 48% in West Africa, and it's a main determinant of cardiovascular disease. And it's the 5th leading cause of death in Western Sub-Saharan Africa. Next slide. To the point that a meta-analysis concerning its prevalence in Benin, Ghana, and Nigeria reported that awareness of hypertension status was less than 30%. So although hypertension is better understood than hepatitis B, it's still not nearly as understood as we would like it to be. And hypertension is accurately attributed to weight gain, poor diet, inactivity, and stress, as opposed to hepatitis B, which we spoke about, is attributed to sexually transmitted infection and due to curses. Participants of an interview-based study from Ghana reported an absence of social stigma involving hypertension. So people with hypertension are more willing to speak about it, more willing to get screened, and more willing to get treated for the disease. Next slide. What happens when people come from West Africa to other countries, such as the United States? Well, as immigrants acculturate, they also acquire risk factors of the new communities. In a survey of West African immigrants in Baltimore, there is a statistically significant positive correlation between length of stay in the United States and the prevalence of hypertension. So the longer people were staying here, the greater the likelihood there was of them getting hypertension. However, even though this was true, immigrants are still less likely to access and utilize healthcare resources than the native-born population, which is attributable to many factors, including lack of familiarity with the health system, legal status, and lower rates of health insurance. So even though in the United States there's a lot of great health infrastructure, people aren't utilizing it because of these barriers. And therefore, people still aren't getting screened, treated, and aren't finding out about these conditions. And it's because of these barriers that the Starfish program was developed. And Fatima, who I'll hand over the baton to, is the main reason that the Starfish program was able to be as successful as it is. And she'll speak to you about how the program was established, what its goal was, and how it was able to be so successful. Fatima?
Yes. Next slide, please. So the Montefiore Starfish program. What is the idea behind Montefiore Starfish program was that the program was developed when the doctor started seeing most of the West Africans coming to the emergency room with abdominal pain. So they were thinking, what was it? And majority of them were detected to be having hepatitis B. And then the program was developed. The aim of the program was just to educate the West African community through an outreach program. It started with a simple questionnaire designed to assess barriers to screening. The program collaborated with local faith-based organizations to facilitate this mission. So we go to churches and mosques, and we also attend the Borough President monthly meeting, which is the African Advisory Council, where we only sit some and just listen to them. And then at a point, they wanted us to share why we're there. And that's when we started talking to them about hepatitis B. So an educational program was developed with a plan to administer the questionnaire prior to events organized from the faith-based organization leadership. And then we will go there and do the presentation. and then recruit those who are willing to come for testing by only collecting their names and their phone numbers. Then we will do the rest after we get to the office. Next, please. So based on the enthusiasm from the educational program, funds were generated for hepatitis B virus screening, and a West African navigator was hired, and an outreach program was initiated after receiving grants from the New York City Council, which the navigator was actually the powerful key that allowed most of the Africans to actually come for testing, because of the way they take the Western healthcare system and the misunderstanding they are getting that they are using their blood for something different. I will elaborate on why I say that almost to the end of the presentation. This was designated to promote compliance of hepatitis B patient with virologic monitoring, hepatocellular carcinoma, surveillance, and treatment. Now, the program includes screening for hypertension, diabetes, core antibody of the patients to make sure that they know what they have. Next, please. So, identifying the gaps we encounter during this program, where some of them are vaccination of the non-immune individuals, compliance with evaluation of chronically infected individuals, high prevalence of hypertension, and rapid translation into ongoing care. Next. So this is just a breakdown of the gaps that we encountered. So we started vaccinating, an expansion of the program to include vaccination services to address this gap. So we did this with an incentive. The reason why we added incentive to that was when we were not having the vaccination and we were sending them to the Department of Health. In the Bronx here, the only Department of Health office that they can go was located in Brooklyn. And so it was very challenging for most of them to go, and we realized they were not going for the vaccination. Those who have been going to urgent care complained they were paying $210 for the 3 shots. And only like 1% did go to their primary care doctors for it. So we implemented vaccination, and surprisingly, almost everyone that needed vaccination came for it. So compliance with evaluation of chronically infected individuals was another challenge. The program implemented immediate comprehensive serological evaluation services with incentive again. And I'm emphasizing on the incentive for the fact that it really motivated a lot of them to come and take care of their illness that they did not understood the severity of what they have. So the remaining gap for the high hypertension was also addressed, and rapid transition into ongoing care was applied for those with high numbers for the blood pressure. Next, please. Okay, so with that being said, I'll pass this on to Julie to speak about hypertension and how a stigmatized disease can correlate with non-stigmatized disease to get people to come for testing. Julie.
Okay, so with one of the most recent initiatives that the Starfish program had started, we were able to screen for hepatitis B in the Bronx West African community using a blood pressure cuff. So in taking all the information we just went over, both hepatitis B and hypertension are prevalent in West Africa. Inadequate hypertension control is common in this population, and Hep B evaluation and management is challenging, especially amongst immigrants due to their unfamiliarity with the US health system. And although Hep B is stigmatized, hypertension is readily recognized as an important condition. And so in order to encourage more screening of a stigmatized, unknown condition like Hep B, we used a non-stigmatized, well-known condition like hypertension. Next slide. So how did we achieve this? So we started with these educational presentations. We had a 30-minute hypertension-based educational program that were delivered in collaboration with faith-based organizations such as churches and mosques. We also had these more brief 5-minute presentations that were often spontaneously requested for at community gatherings. And we also provided an incentive for people to come in for these clinic visits. So people who were interested were arranged to have a clinic visit. They were offered free blood pressure cuffs to come into the screening appointments. And then once they were in these clinic visits, they were given a questionnaire just to get to know their demographics and some of their health history. They were offered blood pressure measurements and a free blood pressure cuff. And then everyone who came into these clinic visits, although they were there for hypertension, we also offered hepatitis B screening for them. And then for those who came in from the presentations, they were also able to refer their family and friends to also come in for a clinic visit. And for those who did not have ongoing care, such as not having insurance or not having a PCP, both of those items were arranged for them. Next slide. And so this is just a graphical representation. You start with the hypertension educational program, you measure their blood pressure at the educational programs, and then once they request an appointment and attend the clinic visit, they complete the questionnaire, get the home BP cuff, and are offered Hep B screening. Next slide. So, and to link people who came into the clinic visit to care, there were many interventions that we provided. For those who were found to have uncontrolled hypertension, which for us we defined as greater than 140/90, who had a primary care provider, they were instructed to contact their PCP in order to get follow-up care. And if an individual happened to have severe hypertension, which we defined as greater than 160/90, there were many options that they were offered. They were either referred to the ED or to a collaborating PCP partnered with Starfish for a same-day appointment as clinically appropriate. And then those who did have these significantly elevated blood pressures were contacted by telephone by our navigator on the following days to make sure their blood pressure were properly controlled. And if for some reason a person had an elevated BP, but were not able to be seen on the same day and needed urgent intervention, they were given a 30-day supply of amlodipine. Next slide. And then to touch on those who did not have insurance or a primary care provider, patients without insurance were enrolled in a Medicaid program, and then patients who did not have a PCP and were eligible were referred to a collaborating West African primary care provider in order to be transitioned to long-term care after their initial screenings. Next slide. So to talk about the very start of this, in terms of the educational programs that were centered around hypertension, there were 7 of the 30-minute presentations held between March 2022 and December 2022. They were held at 4 churches and 3 mosques. And from these presentations, there were a total of 445 individuals who attended the presentations. And then 144 stayed after the presentation to have their blood pressure measured. And out of these 144 individuals, 85 of them had an elevated blood pressure. Out of the people who attended the presentation, almost half of them registered for a clinic visit. And in terms of the more brief, spontaneous presentations, the 5-minute ones, there were 5 of them held between February 2022 and February 2023. And although we don't have the number of those who attended the presentations, as these were more spontaneous, there were 80 individuals who registered for a clinic visit after the brief presentations. Next slide. And then in terms of clinic visit attendance rates after a person registered following a presentation, for the 30-minute presentations, about a third came out to testing out of the 204 individuals who registered. And then in addition to those who registered after a presentation, we often had individuals who went to these presentations who did not register, but then later decided to contact the program afterwards to schedule a visit. And in the 30-minute presentations, there were 18 individuals who did so. In terms of the 5-minute presentations, about 2/3 of them, 51 individuals, came for testing out of the 80 individuals who registered. And then an additional 14 who did not register, but subsequently contacted the program to schedule a visit. And in comparing the attendance rates of these two sets after registration, there was a statistically significant greater proportion of those who registered after a 5-minute presentation who actually showed up for their clinic visit as opposed to those who registered after attending a 30-minute presentation. Next slide. And so with this being statistically significant, we figured that perhaps shorter presentations could be more effective in encouraging individuals to attend these clinic visits. And some of the reasons for this that we were thinking about that we would like to possibly explore more in the future could be that there were some people who we didn't offer screening after the brief presentations, and so perhaps people were more interested in screening as opposed to those who did get screened after the 30 minutes and decided that they did not need to get further screening at the clinic visit. Another reason we were thinking about was that there is more brief, more summarized information within the 5-minute, and so the people who attended those would be interested in receiving more information afterwards. However, that has yet to be explored further. And then if we think about the amount of people who referred their family and friends after a clinic visit, there were 101 total individuals who came from just these referrals alone. And so not only are you getting the people who attend the presentations, you're getting a very large amount of people who were not originally attending these presentations, had not heard of these presentations, but yet they hear from their family and friends to come into these clinic visits, and they actually show up for these visits. And in turn, we get more screening, more people getting connected to care. And out of these, 56 were referred from someone who attended a 30-minute, and 45 were referred from someone who attended a 5-minute. Next slide. And then again, this is another graphical representation to sort of show the flow from attending a presentation to attending a clinic visit. You can see the numbers who registered, did not register, but later contacted, as well as those who were referred by family and friends. And in total, there were 252 who attended a clinic visit within the presentations that were included in the study. Next slide. So let's go over the demographics of these 252 individuals. The mean age was about 54, 55. The majority were male, about 2/3. And then the overwhelming majority of people who came in had Ghana as their country of birth. We also had a select few from Nigeria, a lot from other West African countries. And then there was one person who was actually born within the US, but was part of these mosques, was of West African heritage. Out of these 252 individuals, there were also about half who had a history of hypertension, about a quarter who had a history of diabetes. And then although most of these people had insurance, and then most of them had a primary care provider visit within the previous year, there is still, as much as I would say, a lot of people, about a quarter, who did not have one or the other of these, and which I still think is a lot and is a group of people that should be linked to care as well. Next slide. Going a little bit deeper into the questionnaire answers and the screenings in terms of hypertension. So we have the 252 individuals. About half of them had a history of hypertension. And at the time of the clinic visit, of those who had a history of hypertension, there were 55 who had a normal blood pressure and 79 who still had an elevated blood pressure. And then we still also had half of these people who did not have a history of hypertension. So we're garnering a lot of interest from people who did not have any hypertensive history at all. And the majority of these people, actually 75 of them, individuals, had a normal blood pressure at the time of the visit, as opposed to 43 who had an elevated blood pressure. And so not only are people who are normotensive and have no history of hypertension coming in for a visit, we are also able to at least get a sense of an elevated blood pressure in those who have never had a history. And then out of the people who had a history of hypertension or had an elevated blood pressure at the clinic visit, there were 60 who did not have insurance or a primary care provider within the previous year. And then there were 39 individuals who did have that severe blood pressure over 160/90, and they were referred to the appropriate services as listed in this table. Next slide. And now we're talking a lot about hypertension, and so I just want to tie it back to hepatitis B screening, since this is a Hep B United presentation. This is why we're all here. And so we have a lot of turnout for hypertension screening. And every person who attended the clinic visit was offered hepatitis B screening. And out of everyone, virtually all participants who went for this hypertension screening also agreed to get tested for Hep B. And there were only 2 individuals who actually declined, but they had already been tested for Hep B previously. There were 9 of these people who were previously tested within the STARFISH program. However, they got tested after a hepatitis B focused educational program as opposed to the hypertension ones. And then of the people who were tested for hepatitis B, there were 19 who were found to be Hep B surface antigen positive. Next slide. And so we can see that we addressed the remaining gaps that were still left over since the inception of the STARFISH program, the high prevalence of hypertension and also rapid transition into ongoing care. Next slide. In terms of high prevalence of hypertension, the screening from the hypertension educational programs did reveal a very high prevalence of hypertension, including cases that were poorly controlled or previously undiagnosed. And so in addition to Hep B screening, the program expanded its mission to include a comprehensive program focusing on hypertension, and not only just being able to capture this other significant health problem, but using it as a sort of launch pad to get more West African immigrants integrated into Hep B screening. Next slide. And then we also transitioned a lot of people into ongoing care. So it wasn't just we screen people and then we send them on their way. We also were able to give them the follow-up care as appropriate. And then to ensure continuity of care, the program responded by incorporating Hep B screening and integration of these individuals into the US healthcare system. And then overall, the program's approach involved using this very culturally sensitive education, partnering with the West African community, using the diseases that they find to be important in order to also consider the diseases that we find to be important. We also integrated multiple healthcare aspects and provided comprehensive care for the community by addressing these gaps in Hep B vaccination, as well as evaluation of chronically infected individuals. Next slide. And so I'm going to turn it over to Fatima to wrap up the presentation by touching base on how we evaluate patients who were found to be Hep B surface antigen positive, which not only includes those who were found throughout the hypertension educational programs, but other people who were screened throughout other aspects of the program as well. Thank you.
Thank you very much. Go ahead.
I was just going to say that you were muted. That was all, but you came off mute right as I went to go say that. So thanks, Fatima.
So basically, after all what Ms. Julie just said about hypertension and hepatitis, the main focus is hepatitis B. And so we try as much as possible to integrate an immigrant population with chronic hepatitis B into long-term care, hepatology care. Next, please. So integrating of an individual with hepatitis B virus from West Africa identifies in a screening program into long-term care was very challenging. Inclusion of a serologic evaluation in programs for immigrant communities should be considered, which a lot of them, as Daniel mentioned before, feel like because of the stigma, they don't even share these stories with their family or friends. And so when they are tested positive, they just keep it to themselves. And then also the primary care doctors, I blame them, especially the West African primary care doctors that most of these patients encounter. Once they know your viral load is not elevated, they tell you you are okay, which from hepatologist perspective, you are not okay because you need to be evaluated. Because I have a couple patients whose viral load was elevated. One was 1 million, one was hundreds of thousands, that he refused to come for the evaluation, and then he went to Africa. So tracking him back there just because he came with his wife, just to find out that he's been admitted in a hospital with elevated blood pressure and elevated viral load and was on medication. So he came back immediately when he came. So up to 30% of individuals with serological profile consistent with the hepatitis B virus carrier state may have fibrosis too, which I think is very significant that we need to look into. Next, please. So between 2019 and 2023, 749 individuals were screened from multiple parts of the Starfish program. Beginning 2022, all positive individuals were offered a free serological evaluation with incentive details of the previous diagnosis, hepatitis B care, with serological evaluation, aspirate aminotransference to platelets, radio index, and fibrosis index 4 score were recorded. The results of transient elastography were also measured, were correlated with the serologic evaluation. Next, please. So, result of the evaluation of the positive individuals that we encountered, a total of 75 individuals were hepatitis B surface antigen positive, including 58 previously diagnosed and 17 were newly diagnosed. I remember one of them who actually was diagnosed from another hospital and even had 2.3 centimeters of lesion, but he still didn't know that he had liver cancer until when we called him to come for the result. And he only said he had an operation, but due to language barrier, nobody had sat down with him to explain to him what he had, why that was done to him until when he met us. And so he transited from that other hospital to where we are. So only 14 of those diagnosed before the offer continued and entered into long-term care. A total of 63 of 75 returned for evaluation. Among 56 hepatitis B virus treatment naive individuals had a serologic profile consists of the carrier state. A total of 10 individuals met the criteria for hepatitis B virus therapy, and 10 had fibrosis of number 2, which I feel 10 out of the number we got is high. And this is only among 75 that we tested. So, which means every 75 patients that you check, you're gonna get 10 that has fibrosis of number 2, which I feel is also something that the public health should look into that for future patients. And there was no correlation between aspartate aminotransference to platelet ratio index and fibrosis index 4 scores. 8 patients with a profile of hepatitis B carrier state had this fibrosis. Next, please. So, in conclusion, the importance of cultural sensitive and community engagement in addressing significant medical issue like hypertension, hepatitis B were assessed, which I feel the word cultural sensitive should be encountered by any facility that wants all cultural groups to be part of healthcare initiative. They need to get somebody who is very sensitive, because these West African people, when they come, some of them, especially the positive individuals, Dr. Seeger will intentionally ask them, why did you come? And they will tell him they came because of the West African navigator, which he was surprised that almost everybody will be saying that. Though conditions may be perceived differently, and lack of information and familiarity with the Western medical care can hinder treatment, because they feel that somebody from their own community will elaborate or speak to them with the layman's language that they will understand it much better, for them to know what is the next step for them to do. And also, the culture sensitive can be incredibly valuable. The gap of understanding and acceptance of the Western medical practice was addressed. This was because of another patient also who came for testing. And in the PowerPoint presentation that we give, we have indicated in it that we're going to take only 1 tube of blood for testing. And when they come to the lab here, they've been taking 2 tubes. So one patient actually approached us at the meeting, at the presentation, and said that, what are we using the other tube for? So we have to go back and find out what is the other tube used for, which they were testing for 2 different items. One is surface antigen and the other one is surface antibody. So it's going to different locations. So they were not combining all in 1 tube. So this is something that we need to also be aware of. Whatever we put on the PowerPoints that we're presenting to them should correlate with what we are giving them when they come in person, because they will understand it different. So the gap of understanding acceptance, as I said, easier to provide education, screening, and treatment for conditions that may be stigmatized or misunderstood. It helps the healthcare providers to understand the cultural contents surrounding these conditions and tailor their approaches accordingly. This is also something that I realized with the hepatologists at the liver clinic, which majority of the West African individuals will be told that your viral load is elevated and you need to be on medication, and they'll be like, no, I don't want to be on medication. So the next thing, they will follow me in the conference room and say, Fatima, we have somebody, you have to go and address it. And fortunately, when I go and explain to them with better understanding and knowing that I'm also from West Africa, they tend to accept the medication and start the treatment. And then later they will be grateful that their viral load is very low now and will appreciate us. So this has improved access to care with the Starfish program. Thank you. Next, please. So I think I saw like 4 or 3 questions, and one was, did you offer translation in language other than English, and if so, which were most important? So we have 5 different languages in the brochures that we provided. We have French, we have Chi, that's Ghanaian language, we have Hausa, that is Nigerian language, and we have Igbo in Nigerian language, and then we have English. So those are the 5 languages that we offer. And also somebody was asking about the incentive that we were given, if it was, what was the incentive that we were given? So the incentive basically was a gift card, $50 gift card that the person can use to buy anything they want, or they can go to the ATM machine and just follow the instruction and take their money out. So with the other question, did you tailor your messaging or approach for people of different linguistic background, countries of origin, and other than? Yes, we did. We've been asking all those questions in the questionnaire, and it's not mandatory. If someone don't want to say it, we also don't force them to say it. So following up of Digo's question, what are examples of the messages that the navigator used that were most compelling to patients? So letting them understand that you are part of them, and for them to understand that you're not going to let their blood be used for any other thing other than taking care of them, was very powerful. And then also knowing that some of them had language barriers, that when they come to the front desk of the hospital and see that long line over there, some of them would just make a U-turn and go. So we did assure them at the presentation with the phone number that we provide them. It's a cell phone number that once they reach the main entrance, they don't have to go on any line, but just to call the number, or we let them use the brochure that is provided at the presentations for them to just show it at the front desk that they are here for the Starfish program, and they don't have to go on any line, but someone will just call me and I will come down to assist them for whatever they needed to do. Thank you.
Thank you, Fatima, and Daniel and Julie. That was a fantastic presentation. We actually have had some additional questions come in, so you've answered these first two. What are examples of messaging that the navigator used that was most compelling to patients?
So basically, as I said, is letting them understand. So if, let's say, somebody from Ghana comes there, before I will speak English to the person, I will speak their language, because I speak 3 different languages. So knowing that, oh, she speaks my language too, that means she's not going to do anything to hurt me or harm me. That was very powerful. And that was one of the things that I really motivated people to come for testing. And also with the incentive, people think that when we come for the presentation and we show them the blood pressure cuffs that we use over there to check their blood pressure, when they come to the hospital, we're just going to check the pressure again and don't give it to them. But for them to see that when they come, not even only blood pressure cuff is what they get a thermometer, they get a free bag with other health items that they can utilize, and we give them malaria prophylaxis materials and addresses that they can go to any nearby clinic with their health insurance. We have all the clinics that provide that they can get medication to take to Africa. That also really motivated people to come.
That's excellent. There was there's a new one that just came in. It goes, may have missed this, but what did you do for the household or family members, including children, born to people you identify as living with Hep B?
So basically, the program takes care of anybody above 18. So anyone below 18 that the parents prove to be positive, we will enforce and advise the parents to go back to their primary care doctors for follow-up and let them understand the percentage of 95% of children, if not being monitored, will end up with chronic hepatitis B from statistically study, so that they will understand the importance of taking the children to their primary care doctors.
This is a question I'm asking. Question from Frank Hood, HBU. I am very surprised to hear that so many people were willing to get a blood draw. So they walked in expecting a very non-invasive blood pressure reading and walking out with some of this medical equipment, but to be able to convert so many of them into actual blood draws, where that kind of having blood taken is just a barrier in general. I get you've mentioned all this other messaging, but like, how did you nail that piece? Like, how did you get people over their fear of needles, not only for the blood draw, but I guess the vaccine too? Like, that is really impressive.
So first of all, I will say that the impression on your face really matters. No matter what you're going through, the approach should be the key. And not only just reading the questionnaire and asking them to answer it or whatever answer. No, you have to make it more fun. Asking them where they're from, and the person say, oh, I'm from Ghana. Immediately the person say that I will speak the Ghana language to the person. And this is like open room for the person to be more comfortable to what you are going to approach them after. And if I don't speak your language, I may have one word as a joke that I will say, how did this happen? It's just to engage the person, and that engagement let them understand and become more comfortable. And then asking them, have you ever tested for hepatitis B? Somebody will say, yes, I have been tested. And then the next question will be, what was the result? So people tend to say, oh, they said I'm negative, because they're trying to avoid the blood drawing. They'll say, oh, they said I'm negative. But I try to explain to them, even at the presentation, negative is not an answer when it comes to hepatitis B, because you could be negative for two things, either the surface antigen or the surface antibody. So which of the two were you told you were negative on? And that is what usually threw them off, that they don't have the answer to give me. So where is the answer now? Your blood drawn will let you know which part you are. And assuring them that if you were given a copy of the result of what you had, this might have prevented you from taking your blood today. But I'm assuring you that after we test you, I'm going to mail you the results that you can keep either on your phone or in your drawer. Whenever somebody asks you about hepatitis B, you're not only going to say you tested negative, but you have an answer in your envelope to provide.
Got it.
Yes.
That's slick. Julie just answered a question around offering this education presentation outside the screening clinics. I wanted to have a couple other questions. How did you get the incentives?
So basically we had a patient who died with chronic hepatitis B, and his parents donated some money to us just because of the way they see we've been changing people's life from getting just hepatitis B and preventing them from being chronic. So we were using that money, and also the evaluation funding that was provided from one of the pharmaceutical company. Part of it was also used, and some donations that Dr. Seeger got from other big companies were used for that incentives.
So it's a combination of different sources,
Yeah,
but
yes.
it really sounds like you proved an impact in your community, and your community kind of paid it forward back to you, and then you've turned that back into this even more significant impact. That's great to hear. Thank you, Rensley, for asking that. There was a question from Riddy. Sorry if I mispronounced that name. Were there any physical or digital communications or like advertisements to get folks into the door for this program?
Actually, I would say it's physical, because we go in person, do the presentation, assuring them that me that you see here giving you the presentation is the same me that you're going to come and meet when you come for testing. It's not going to be another person. If there is another person, you will still end up seeing me with that person to make them comfortable that whatever we are telling them there is what they are going to see.
And so when you follow back up with them to convince them to take that blood draw, it's not that you had just started that relationship there. You'd actually started it all the way back at the initial setting. Okay.
Yeah. And then with the lab, usually lab is fully packed all the time. But for the Starfish program, all what you can spend over there wouldn't be more than 5-10 minutes and your blood draw is done. Because of the West African personnel, how she takes care of the blood drawers, friendliness is the key. When you want people to do something for you, you have to be able to communicate well and friendly with everybody. And if I have 10 patients that need to draw their blood at 9 o'clock, trust me, all of them will get that blood drawn at 9 o'clock. Because if it's 10 people going there with just a small incentive token with the Starfish phone and pen, I will just take 10 over there, hand one to each of them, and then the next thing is, I need 10 people's blood draw. And everybody will just take one, and by 10-15 minutes, they are finished and gone.
This is amazing. We actually still have more questions coming in, so I'm just going to keep firing them off because this has been so informative.
That's okay.
Other than hypertension, are there other potentially less stigmatized conditions that this could be used for a project like this?
Hypertension is actually not stigmatized among West African communities. Diabetes, not.
Okay, diabetes.
No. People will tell you they are diabetic, people will tell you they have hypertension, but only a few people will actually tell you they have hepatitis. Because I had a lady who actually was told by her doctor to come and see hepatology here. And I know her from the community. And it was during COVID, she had a mask on. So for confidentiality purposes, when I saw her, I also pretend I didn't see her because I know how stigmatized people are. And so she may be scared seeing me there that maybe I'm going to know what she had or something. So she kept her mask on until when she realized most of the West Africans that are coming in are looking for Fatima. Then she texts me and said, are you the same Fatima that I'm seeing running up and down at the clinic? I said, it's me. Then she felt comfortable. So as I said again, presentation is the key. You have to try and be neutral with everybody and let them understand. Them coming to us is not different from them going to their primary care doctor. Whatever we do to them is confidential. And we're not going to go out and say anything to anybody. It's their business and we don't have to intervene.
And just to add on to that, the program was successful in screening for diabetes as well. People who came in for hypertension and for hepatitis screenings were taken for screening for HbA1c. So they got screened for diabetes, and it was a very successful program in that as well. Paper will be published soon about that.
Absolutely.
All right.
Yes.
I have one last question I saw in here, our last minute and a half, and it was, from your learnings, what would you expect to scale to other African immigrant communities? What was specific in your program that was designed for West African? So I think it's saying, like, how could this be scaled to not the other African communities that aren't necessarily West African?
So basically, I would say that the brochure that we translate from different languages was helpful. And also, the key leaders of the community are the main people that you need to communicate in order to be able to go and present to the community. So it doesn't really have to be a different community that West African community that I can present to. I can present to any kind of community so far as the leaders allow that. And for that being said, when we went for the West African Heritage events, Not only the West Africans come for testing, but we do have a lot of Spanish people and Black Americans that are coming for testing.
So you think, I mean, it seems like it's able to be scalable now, and really just, the cultural sensitivities and the language sensitivities really help drive a lot of that, as well as what just seems like fantastic best practice and relationship
The
building.
language also is very, very important in the sense that when you are breaking down something medically that someone don't speak English very well, you have to break it to their understanding for them to know the severity of what they have and how going for the 6 months evaluation can change them from what they are carrying to non-detected viral load.
Another important point that I just wanted to highlight is the cost effectiveness of the program. Obviously, besides for the incentives, which were given to us through an outside resource, Fatima was the only navigator, really. Obviously, Fatima is a workhorse and she is a superwoman, so she was able to do a lot of this on her own. But she was the only navigator who was going to the churches and mosques, and the phone number that was provided was basically all going to her. So important to highlight that this can be scaled to much larger populations if you have access to more culturally sensitive professionals.
Thank you.
All right.
Just to elaborate on what Daniel just said, when I joined the Starfish program, actually, the lady who was calling patients were giving her wrong phone numbers, wrong date of birth, and everything, because she was using the hospital number to call them, in which they think it's a scam, is whatever. So using a private cell phone for patients is also very important, which they do understand. Is the lady that we saw is the number she provided, and she's the one calling. Thank you.
Yeah, no, that's a great call. Well, thank you, Julie, Daniel, and Fatima for this fantastic presentation. We have been recording it. Looking forward to getting this published. This was such an informative webinar, and really looking forward to when that diabetes publication comes out, because we'll happily have you back to speak on that one. But really just, thank you for coming on, and also thank you for the 20+ attendees who came on. That was some really, really solid Q&A, and really glad that we were able to fill our time plus a couple extra minutes. And if folks have other questions.
Just to let you know that Dr. Emmanuel has been part of the participants listening, and he is the one who actually coached me, led me to what I am today.
Oh, that's a great shout out. Well, really do appreciate all that you're doing for the communities in the Bronx and elsewhere, and really looking forward to see what else Starfish is going to be putting out, and looking forward to hopefully having you and Julie and Daniel on again before too long. Thank you all, and we'll be sure to follow up with these slides and notes and recording, and just reach out if there's anything we can do.
Thank you.
Thank you all.
Okay.